I am Dr. Maxine Jochelson, and I am speaking to you from Memorial Sloan Kettering Cancer Center, where I am the Director of Imaging at the Evelyn Lauder Breast and Imaging Center. There is a lot of controversy, or at least unsettled recommendation for monitoring women who have had breast cancer. And I think there's a couple groups. There's the woman who has both of her breasts intact, and then there's the woman who's had a mastectomy. Okay, so let's start with women who have two breasts. The first thing that is important to know, while there are institutions that start re-imaging the lumpectomy breast every 6 months, there is no value in doing that. So these women should be having yearly mammography, and there are good data to show that by doing yearly mammography in this population, you are reducing mortality significantly because you're going to find that early recurrence or an early second primary. The bigger question has come up as to whether or not we should be doing MRI in these patients. And there have been quite a few studies, and they all demonstrate that, yes, in fact, you increase your cancer detection rate. The more studies you do, you always find more cancers. But the question is, are you finding a lot of stuff you don't want to find? So there is a really nice article published by Connie Lehman where she compared the additional detection rate using MRI over mammography in women who just have a personal history of breast cancer to those who have a genetic history, so the mutation carriers. There are no arguments that mutation carriers should have regular MR. Well, it turns out that the additional cancer detection rate is similar between the women who have personal histories and the women who have genetic histories. And in fact, the specificity in several papers is better because you've already had one MRI. Now, I don't believe, and I think this is also true, less so for mutation carriers, that the rate of recurrence in breast cancer patients stays the same. There was a wonderful paper by Puglia et al. In 2010 from JCO. And what they did was they looked at younger women presenting with breast cancer. They had women who were hormone receptor positive and other markers. And they looked at their risk for developing breast cancer. What was really interesting is the younger women had a 20% or greater risk, just like a mutation carrier, for developing breast cancer. But it wasn't a lifetime risk. As they hit later middle age, their late 50s, 60s, then the risk goes down. So that's different from mutation carriers where the risk stays up. So ideally, you would take a woman who presented as a younger person and perhaps consider doing MRI regularly until she got to be 55 or 60 years old. And the literature, it makes sense because we know the older patients get fewer second tumors or local recurrences. So that is the ideal way to do it, I believe. And then I'll throw in the contrast mammo because that is another option. We do a lot of that in our post-lumpectomy women with dense breasts, and we have demonstrated, although we don't have all the large populations yet, that we do find more cancers than just on regular mammography. And again, it's less expensive. There are two papers in the literature, one from one of your colleagues at the BI, Jordana Phillips, where they've demonstrated women would much rather have a contrast mammo than an MRI. One other thing, just the post-lumpectomy patient in the immediate post-lumpectomy situation in a woman who's had calcifications, there's also a question as to whether to do a magnification view to look for residual calcifications prior to radiation. And it is not done as standard of care anymore. It used to be. We recently did publish a paper, and we looked at people with positive margins and negative margins. Most people don't argue. If you have a positive margin and you had calcs, then a post-lumpectomy mammogram is worthwhile. What was interesting is women without positive margins, we actually had a 6% cancer detection rate by doing the post-lumpectomy mammogram and found residual calcification. So that's a value judgment, but I think if a woman's had a lot of calcs, it's probably worth doing. The one time I wouldn't do it is if the woman had only a few
calcifications, they were completely removed at stereotactic biopsy. There's no point to torture her with a post-lumpectomy mammogram.